Just heard me speak. I'm one of our new members of the board of directors, and I get the honor of introducing Dr. Sandi Lam and Dr. Ben Kennedy today. Dr. Lam is a pediatric neurosurgeon and a leading specialist in the areas of pediatric cerebrovascular surgery, epilepsy surgery, and craniofacial surgery with a focus on minimally invasive and endoscopic techniques. In addition to her clinical experience in complex surgery, her research focuses on quality outcomes and healthcare utilization for children and neurological surgery. She is a member of the board of directors of the Pediatric Epilepsy Surgery Alliance as well. And yes, thank you, Dr. Lam. And Dr. Kennedy is the director of epilepsy and functional neurosurgery at Children's Hospital of Philadelphia. His primary interests include hemispherectomy, minimally invasive and skull-based approaches, HIFU, and neuromodulation, including emerging indications. Yes, thank you to the both of you, and I'm sure everyone here is so excited to hear what you're going to speak on.
Thank you so much. It's awesome to be here. I recognize that we have people from all walks of the journey, of the epilepsy surgery journey. So I'm going to spend the first few minutes just kind of level setting for everybody for why epilepsy surgery, even though we're an epilepsy surgery conference. And then talking about minimally invasive epilepsy surgery, which is near and dear to my heart, and also Dr. Kennedy's practice. So we're really going to show you a lot of the really exciting innovations and technical advances that has happened in the past couple of decades. So there's a lot of minimally invasive techniques now with different tools such as lasers, robotics, endoscopy, and covered in yesterday's fantastic session, neurostimulation. So we won't talk about neurostimulation that much today, really, but we'll talk about minimally invasive techniques. So, but why are we doing this? We're going to show you little fancy things, but why, right? Ongoing seizures are detrimental to the developing brain. So we want to stop those seizures and really not have kids exposed to ongoing medications and the side effects from that, and also to try to address the developmental stagnation or regression that can happen from it. So our goals are really seizure freedom or reduce the seizure burden and improve the quality of life and really capitalize on children and their developing brains. So when we think about medications, there are actually so many on the market now. When I started in my training, there were much fewer, and now that it's more than tripled or quadrupled to more than 30. So the narrative is always like, well, we can try another one. We can try another one, right? If you look at this table, that when you are on your third, fourth, fifth, or sixth medications, your chances of achieving seizure freedom drop to less than 1%, right? So internationally, the consensus from an expert panel around the world actually look at when you should be referred to surgical evaluation, and it is essentially anybody who has epilepsy, who is not in the octogenarian age group should be referred for epilepsy surgery. And it's a referral, it's an evaluation. It doesn't mean you have to have surgery or a certain type. It means that you should have a multidisciplinary team look at what's going on. And we know the outcomes of the seizures are actually way better after a multidisciplinary evaluation, no matter what surgery or what medication or what comes from that. So here I want to highlight the burden of epilepsy. We all here in this conference live it and know it, right? But I also want to highlight that there's a much higher risk of premature death. We don't talk about that much. So the risk of death is from ongoing seizures it could be from sudden unexplained death in epilepsy, it can be from suicide, it can be from accidents. And if you look at kids living with epilepsy, that rate is even higher than adults living with epilepsy. So that's where we get the 5 to 10 times higher rate of mortality or risk of death than other children living without epilepsy. So this is kind of like preaching to the choir. We all know epilepsy surgery works, right? So over 25 years ago, there's a randomized controlled trial that showed that epilepsy surgery works and has much higher surgical seizure control rates compared to medically treated kids or adults in that study. And then now we look at there's more surgery being done, but really not that much. We're only maybe reaching 1 in 3 people who may benefit from epilepsy surgery. Even though we've shown this in adults, we've shown this in kids, we've shown this in any which way you can measure it. You can, after surgery, you'd go to the emergency room less, you would be on less medications, you can wean off medications. We're not, like, why are we only reaching 1 in 3 people who may be able to benefit from surgery? So we're this is one of the ways that we're thinking may help, is that if there are options that are kind of smaller, right, or minimally invasive, would that make it less of a leap to think about surgery when you are living with ongoing seizures? We know that from a medical and surgical perspective, if you look at pediatric epilepsy surgery, all comers, the blood loss and blood transfusion has historically been actually one of the most common perioperative events in terms of risk. Okay, we think of all sorts of other risks, but if you just look at all comers, no matter what center, blood loss and blood transfusion is a big thing that we worry about. So at our center, and you'll also hear from Dr. Kennedy's center, one of the things we really focus on is minimally invasive techniques. And that does not compromise the seizure outcomes. That means, can we do the same surgery with the same great benefit, but actually make it easier on the patient and make it easier on the families and make it faster to start going for, to get towards the road to recovery. Sometimes you'll hear that somebody is too young or too small for epilepsy surgery, and that's not the case. So that's something that minimally invasive surgery can help with, that we actually make smaller cuts and smaller exposures. But if you look all around the world, we participate in an international study looking at kids less than 3 months of age who had epilepsy surgery, and we demonstrated that it was safe and it was effective. And the other thing is, what are you going to get from surgery, right? We talk about seizure reduction, we talk about a better quality of life, we talk about development or medications, and I also pointed out survival. So our group did a national study looking at over 18,000 patients, medical therapy versus VNS therapy versus cranial epilepsy surgery. And here you'll see it kind of bigger. At 10 years, when you look at who got what, the people who got surgery were much more likely to be alive at 10 years compared to those with VNS in the middle, and then those on medical therapies. So that's kind of the last part of why surgery, right? And we'll talk about why smaller surgery, but why surgery? So if you look at the people who are treated with medications versus VNS versus cranial surgery, brain surgery, the difference isn't subtle, right? Those who are treated with brain surgery were 98% chance of being alive at 10 years versus those with medical therapy were 89% chance of being alive at 10 years. So while surgery sounds like a big step and scary, this is also very, very eye-opening. So if you think about it in another way, how do you reduce the risk of death? You can reduce the risk of death by doing something. And that's the point of working with your surgical teams. So if you think about epilepsy surgery in terms of public health, right? It's actually how do you prevent deaths? And we know that we aren't getting to enough people that we can help, and that there's actually problems in access to surgical care, right? If you look kind of across who's at the conference now, you're going to see a lot of people who look, who kind of look like each other, right? Are kind of like white, educated, advocating for the kids, and we really need to represent everybody so we can really have knowledge as power. So that's kind of my little prelude to why we're super excited about surgical innovation, because we are actually getting better and better at doing epilepsy surgery and getting people on the road to recovery faster. So you'll have a few examples of how this happens, and I'll also talk about all of the cool toys that we have, and you're hearing all about all the cool toys that we have and all of the things that we're excited about in different sessions. But there's gonna be things like lasers and computers and all these other things. Focused ultrasound, right? Which is it doesn't even make a noise. You can't even characterize it. Like we have to go just to make a noise to like show that it's doing something, right? But there's going to be all these like really cool technologies, and then everybody's going to say, we need that, we need more of that. And then honestly, as a field, and we all have to keep each other honest, is the surgeons and the patients and everybody are going to want to do this on everybody. And then we're going to realize, you know what, maybe that wasn't awesome, right? Just because you have a hammer doesn't mean that everything is a nail. And that's why we actually need to work all together. And that's why a multidisciplinary team is a really big part of epilepsy surgery. Even though we talk about the surgery, we need everybody involved and all of the team players, right? With the neuropsychologists, our epileptologists, our neuroradiologists, like Dr. Wijaya just gave an awesome talk in the previous session, actually showing that every teammate, whether you meet them or not, makes a huge difference in the surgical outcomes. Just like an experienced neuroradiologist who specializes in epilepsy is actually going to help the whole team get better seizure outcomes. So what's all the fuss about with all the huge teams is like we're trying very hard to figure out where the seizures are coming from. So you'll see a whole list of scans and more with like post-processing of all of these things and things that we are trying to consider for quality of life, for where to avoid, where not to avoid, what is something that we can rehab through. This is kind of like an old school way of thinking about epilepsy surgery, is where are the seizures coming from? We're evolving a lot more in neurostimulation to think about, what is the network that can kind of control the whole the network of where the seizures are coming from, and how do you tell the brain to calm down. But and every program is going to be a little different, but when you are presented with somebody with seizures and you're trying to figure out where they're coming from and why somebody has seizures and what we can do beyond medications, everybody's going to work through a different type of algorithm to figure out what type of surgery is going to be best to try to control the seizures. But a lot of that is actually you need to get information, right? So getting the information means that you could have phase 1 or phase 2 or more types of workup to get the information. So everybody, when you get to the phase 1 evaluation for epilepsy surgery, is actually your history and physical, like what your seizures look like, your video EEG, and all sorts of imaging and neuropsych. That's what all the teams talk about together. When you have the imaging, trying to figure out, is there something that looks lesional, that looks guilty, right? That we know where the seizures are coming from versus non-lesional. And then based on all of that, then we can actually talk about what all the options are. So then you'll hear a lot more about options, but I'll show you a few cases, because really the decision-making is going to be very, very individualized at this point, right? Once you get the workup, it's going to be building trust with your team and actually trying to figure out, does that make sense to me? Is this something that I understand, and that, this is something that the team has experience in, and this is something that our family wants to choose. But in terms of from a surgeon, actually, when I started training, 20-something years ago. Actually, this was kind of like our main way of getting into the brain. It was a big, kind of question mark shaped cut or a T-shaped cut to get into the brain to do seizure surgery. And now we actually have ways where we don't have to make those big cuts, and we can use endoscopes, little cameras, we can use lasers, and we can use other things that are much, much smaller cuts to be able to actually achieve the same, if not better outcomes. Same outcomes in terms of the understanding of seizure control or seizure freedom, but better in terms of actually having a much, much shorter recovery time, and actually a better complication profile, less blood loss, less damage to any other surrounding structures that are very, very close to the areas of interest. And Dr. Kennedy will talk about things like hypothalamic hamartoma, where those things are really important. So now I'll give a few examples. So this is a lesional case. And this is something that we chose to use a laser on. So this is a child already in school, a very good athlete, and that we found as a team a place where we saw was guilty, and it correlated with the EEG. So in order to get into a deep area now, we don't need to do these big incisions anymore. We can actually say, what is the right tool for this problem? For this problem, the laser tool actually made a lot of sense for us to get into a very deep area where we don't have to make the big cuts. So when we do a laser ablation, it is a small incision in the scalp, a very small hole in the skull, enough to pass a laser into the brain tissue. And we actually, the laser creates a thermal energy or thermal ablation, and we actually destroy that area where the seizures are coming from. So it can be stereotactic laser ablation, magnetic resonance guided laser interstitial thermal therapy. And this is what it looks like here in real time, where we have the laser placed, and then we're actually running the MRI to be able to help us infer the thermal energy to see how we're destroying that lesion. You can see it's relatively deep in the brain, but if we're inserting a little laser cannula, it's actually much smaller than if we had made the big cut to try to get our instruments in there. And then somebody like this would be able to go home the next day, the next morning with one little stitch that would dissolve. If we need more information where there isn't one very obviously guilty area, then you would actually need phase 2, which means you would need, instead of having EEG stuck to the outside of your head, on the scalp and recording the video EEG, you would actually need EEGs or electrodes inside the brain to be able to record in more detail where the seizures are coming from. You'll see these are different examples. There can be grids and strips where you would need to make the bigger incision to put the electrodes on top of the surface of the brain, or you can essentially put the electrodes in where you kind of make very small pokes. I would call that, it's not invasive, right? Because it's poking into the brain, but we want it to be maximally effective while minimally invasive, okay? So this we have to plan very carefully to be able to insert the electrodes in to avoid all the blood vessels in the important areas. So here we would use either a stereotactic frame or Rosa the robot or AutoGuide. There are different robots that will actually help hold the trajectory and help the surgeon hold and plan while we insert that very carefully. Here's a picture of what the electrodes will look like. So actually when you put the electrodes in, it's the little metal contacts that are actually recording from the brain tissue and actually recording as we're waiting for seizures. So once we have those electrodes in, we want to, based on what we think, where the seizures could be coming from, then we want to record and capture the seizures. We don't want to put electrodes where we have no reason to, but we want electrodes where we need to either say, well, can we figure out based on this information, is it guilty or not guilty? So say in the ROSA planning platform, this is how we would actually plan the different electrodes to be able to all work together with the neuroradiology, epilepsy, and neurosurgery teams to understand where they're going and how we record these electrodes. So in graphical format, this is what it would look like, and what you'll see is something hanging out from the skin. So, as an example, this is a school-age child with lots of seizures every day with tuberous sclerosis, so many lesions, and trying to figure out where the seizures are coming from to develop the best treatment plan, right? It would not be appropriate to take out every lesion that we saw in the MRI because it's really taking up a lot of the brain hemisphere on that side, and it's actually just because we see it doesn't mean it's guilty in causing the seizures, right? So here we actually needed to put the electrodes in to try to figure this out. And as you know, the left side is often responsible for language understanding. So once we did that, we could also map in real time and actually simulate the electrodes and see are these areas important to language understanding, memory, generating words or receiving words. So here it was not appropriate after we did all of the mapping to actually remove those areas causing the seizure. So we put in a responsive neurostimulator, just like you saw in the neurostimulation session yesterday. So we're able to use those areas and use that information from the phase 2 to place an RNS. You heard about this yesterday. So this is an implant that would monitor for the seizure activity and try to give it a pulse to stop the seizures before they start. And I'll end with an endoscopic hemispherectomy example, which will set the stage for even more cool minimally invasive surgeries that Dr. Kennedy will show you. And this is another way of looking at minimally invasive, just looking at all these different strategies. So this was a school-age child with Rasmussen's encephalitis with getting progressively weaker over time and with a huge seizure burden. So this child was a hemispherotomy candidate. The way that I do it, and everybody will have a different kind of modification. My personal technique is the endoscopic hemispherectomy technique. So anybody over the age of 1 year old in my practice actually doesn't require a blood transfusion when we do a hemispherectomy because of the small incision that we make, and we disconnect from a vertical approach. But no matter what terminology from the side, from up top, hemispherotomy, hemispherectomy, all of that is actually you need 4 cuts to disconnect the bad side of the brain from the good side of the brain. Those are the disconnections. We make the same disconnections on the inside, but we just have a smaller incision on the outside. So there's really no swelling in the face. There's no pain when you chew, and patients are able to start therapies immediately the next morning. So this child with this hemispherectomy technique endoscopically has been seizure-free since surgery. So rather than the big question mark shaped cut, we have the few centimeters up top. And we're actually able to do this in other parts of the world now because of the minimally invasive nature, not needing the big blood transfusions. We're able to actually help our colleagues in other parts of the world understand that you can do epilepsy surgery, you can help people, and you can do this in a way that's safe. 80 million people in the world live with epilepsy, most in low and middle income countries, actually. So we have a partner program in Uganda where we use the same EEG equipment, and we have regular epilepsy conferences. So now we're able to do spherectomies through the vertical approach with the endoscope or a microscope without blood transfusion. So this is actually our first hemispherectomy candidate and patient in sub-Saharan Africa last year. So now we have this ongoing collaboration, but that means that we have to be able to do this safely. right? And that we have to be able to look moms and dads in the eye and say, I can do this. I can do this with the tools that we have, and we can make sure that we're doing the right thing for you guys. So epilepsy surgery is safe and effective, and actually not only safe and effective, but actually helps people and can help people live longer. Living with epilepsy, and we have lots of tools. And living with epilepsy is scary. I know surgery sounds scary, but I think living with epilepsy, when you look at all this, is actually scarier, right? So welcome to contact us at any time. We have same day access if you really want to talk to somebody, or we'll get everybody usually in within a few days. And then there's ongoing research. Surgery isn't the end all and be all. I do think it is the end all and be all for a lot of people living with epilepsy, but we do a lot of comparative effectiveness research and understanding families' journeys, whether or not they choose to have surgery or not. So come by the Lurie Children's table. We'd love to get you involved in our research. So we need to learn from you to figure out, how do we reach more people? How do we do this safely? How do we get you guys through your journey and watch the children grow up, be parts of your lives? It's an honor. Now Dr. Kennedy is going to show you super cool things in our world.